Okay, can you see my screen there? Okay.
Yes.
All right. Good afternoon, everybody. I'm Julie Kalkbrenner with Lurie Children's. I'm one of the physician liaisons for the West and Northwest suburbs. Thank you for joining us today as we introduce you to the Lurie Children's team, a division of orthopedic surgery and sports medicine. For this session, I am introducing Dr. Eric Fuller. The Division of Orthopedic Surgery and Sports Medicine at Lurie Children's is nationally ranked by the U.S. News and World Report. We care for more than 30,000 children each year, providing a range of services for children with bone, joint, muscle, ligament, tendon, and nerve disorders, and offer the only pediatric bone health program in Illinois. This is how we are able to recruit the finest specialists in the nation, such as Dr. Fuller. Dr. Fuller is an attending orthopedic surgeon at Lurie Children's and a clinical instructor at Northwestern University Feinberg School of Medicine. He completed his medical education at Rush Medical College and residency training at Northwestern. This was followed by a fellowship in pediatric orthopedic surgery at Stanford with a focus on pediatric spinal deformity. His clinic interests include scoliosis and other pediatric spinal disorders, and his practice is open to all pediatric orthopedic pathologies, including fractures, clubfoot, hip dysplasia, limb deformities, and some sports injuries. He sees patients exclusively at Silver Cross in the new Lenox clinic location and takes trauma call and has operative privileges at Silver Cross Hospital as well. As the sole pediatric orthopedic surgeon at Silver Cross, he tries to make himself available for ER consults and to the PCPs in the surrounding area every day, even on days that he is not on call. The unique partnership between Lurie Children's and Silver Cross Hospital allows him to deliver academic quality care while still practicing community-based medicine. For today's presentation, I'll be turning it over to Dr. Fuller in just a moment, but we do have a chat box that you are able to type questions in, and we'll address those with Dr. Fuller at the end of the program. So I will now introduce Dr. Fuller, who is going to discuss with you adolescent idiopathic scoliosis. So I am going to make you the presenter, Dr. Fuller.
Okay.
Okay. All right. Okay.
Okay, is my slide showing up?
Yes.
Perfect. All right, well, thank you for that introduction. Today we're talking about adolescent idiopathic scoliosis, something that's somewhat of a passion of mine. And the reason I wanted to take this talk is that the current referral guidelines really don't take into account some of the newer, more aggressive treatment we're doing these days. Classically, hold on, something just popped up on my screen that's in my way. There we go. Classically, the referral guidelines are for curves above 25 degrees because that was typically when conservative treatment was initiated. But nowadays we're doing a more comprehensive conservative treatment starting at earlier curve progressions. And this has been shown looking at the literature to actually prevent the need for surgery. So in order to initiate this treatment early and effectively, we actually need to start getting referrals sooner than what was classically taught to probably most primary care physicians. But we will get into the background of adolescent idiopathic scoliosis, and we'll talk about the clinical setting, some indications for referral. I'll talk about my conservative treatment protocol I use, which I've called the trifecta of treatment. It's my moniker, no one else uses that. And then we'll talk about operative treatment, including indications, some post-operative course, and the risks. So scoliosis is defined originally as a lateral deviation of the spine from the vertical midline exceeding 10 degrees. Anything less than 10 degrees is just considered spinal asymmetry and is actually a variation of normal. It's not until we cross that 10-degree threshold that it actually meets the definition of scoliosis. That being said, that's an old definition. Scoliosis really is a three-dimensional deformity and the real deformity is a rotation, which we'll get into later. Idiopathic, meaning just it's a non-congenital structural, syndromic, or neuromuscular cause for the scoliosis. And then adolescent scoliosis is when it's first diagnosed above the age of 10. Anything before that's considered early onset scoliosis and is a much more concerning diagnosis to have. Adolescent idiopathic scoliosis together makes up about 80% of all scoliosis diagnoses. And the prevalence is about 1 to 3% for all curves above 10 degrees, but those traditionally requiring brace treatment, it's only been about 0.3%. And scoliosis is traditionally thought of as affecting females way more than males. And while that's true for curves that require surgery or bracing, for minor curves from about 10 to 25 degrees, there is a 1-to-1 ratio. Now, what causes scoliosis is really unknown at this time. There's a lot of research going into it. It's believed to be multifactorial and mostly attributed to genetics. What I like to tell patients that does seem to relieve a lot of angst that the parents are having is that this is not caused by activity or inactivity, doing too much sports or not enough sports. It's not from poor sitting posture. It's not from heavy book bags or diet. Essentially, it was something they were born with. It just didn't become clinically relevant until they started getting close to their growth spurt. And there was really nothing they could have done prior to the diagnosis that would have prevented it or made it less severe or anything they did to cause it. One of the leading theories of what causes scoliosis is this idea of anterior overgrowth, that the front of the vertebra of the spine is growing faster than the posterior elements. And in order to accommodate that extra bone, the spine actually has to rotate in order to make room for that extra bone. And then when it rotates, it comes out of the midline, and then this causes the distribution of body weight to lay down unevenly on the growth plates of the spine, which further contributes to the growing deformity. So essentially, the root cause of the scoliosis is a rotation, not a lateral deviation. And you can see that here on this X-ray. A normal X-ray above and below the scoliosis, if you mark out the pedicles in the spinous process, almost looks like a little face of an owl that should be looking right back at you. But you can see at the apex of this patient's deformity, you can only see one of the owl's eyes, and its beak, the spinous process, is quite rotated as if it's looking the other direction. What this essentially is doing is the normal sagittal plane of the spine, the lumbar lordosis and the thoracic kyphosis, since the spine is rotating, it's essentially taking that lordosis or kyphosis and turning it into scoliosis. As you can see on this lateral X-ray, this patient's spine on the lateral side is actually very, very straight, much too straight than it should be. And that's because the curve that should be there is actually in the coronal plane. Now, screening has been an area that's been quite debated in the past. Back in 2004, the U.S. Preventative Services Task Force had actually recommended against routine screening. And the basis for this was because there was a lack of evidence that non-operative treatment was successful in reducing curve progression. But since that study, or since that recommendation, there have been some studies, in particular bracing study, that shows that bracing does work. And we'll get into that study a little bit later, as well as scoliosis-directed physical therapy is effective in reducing curve progression. And so therefore in 2018, they updated the recommendation to insufficient. And the reason why that is because there still is not any good long-term studies on our current surgical treatment, mostly because our current surgical treatment keeps changing and gets advanced faster than the literature can keep up with. However, the American Association of Orthopedic Surgeons, Pediatric Orthopedic Society of North America, and the AAP all recommend routine screening. Girls should be screened twice at the ages of 10 and 12, and boys should be screened once between the ages of 13 and 14. However, school screening has largely been abandoned due to high false positive rates. Turns out having gym teachers who have no medical background doing screenings was not a good idea. In the clinical setting, one of the easiest tests to perform is a combination of an Adams forward bend test using a scoliometer, which is like a level, just to determine the rib prominence of the spine. This has a 71% sensitivity rate and a 97% specificity. There are some screening tests that have a better sensitivity, but they're not really accessible in the primary care setting. The original recommendation based on this exam was for any 5 degrees of rotation on the scoliometer that referral to an orthopedic surgeon was recommended. This roughly correlates to about 20 degrees of scoliosis on X-ray. There is a 4-to-1 ratio of scoliosis to scoliometer rotation, although that number is not very exact. However, that had in the past was leading to a lot of unnecessary referrals to orthopedic surgeons, and they weren't getting they were getting a lot of referrals that did not need treatment. So then they upped the guidelines to 7 degrees of rotation on the scoliometer, which is roughly about 30 degrees of scoliosis. However, in my practice, as I mentioned earlier, I actually start very aggressive, conservative, non-surgical treatment as early as 10 degrees, and therefore my preference is to base referral on an X-ray if that's easily obtained at a primary care setting. And the cutoff for getting an X-ray should be about 4 degrees of rotation, which is roughly about 10 to 15 degrees of scoliosis. When evaluating these patients in the clinic, certainly we want to get full history, including a family history. Interestingly, when mothers have scoliosis, typically the daughters have scoliosis of the same severity, and sons typically have less severity. So if moms needed to be braced, sons may not even need bracing. Whereas the opposite is true for the fathers. If a father has a positive history of scoliosis, the sons tend to have the same severity, but daughters end up being much more severe. If a father needed to be braced, very often the daughters may progress to need surgery. History should also exclude any congenital, neurological, or syndromic causes for scoliosis. Physical exam would include a neuro exam of the lower extremities, motors from L2 to S1, a sensory exam from the umbilicus all the way down to the big toe, checking the lower extremity reflexes and a Babinski sign. And any abnormalities is an indication for an MRI, although this could be deferred until after orthopedic evaluation. So if the scoliometer is above 4 degrees and it is easy to get an X-ray in clinic, my recommendation is to get a PA and lateral standing X-ray of the spine. I very often only when I get a referral from a PCP's office, I very often only have an AP, and unfortunately I do have to get that lateral then, which causes more radiation exposure. The reason why a lateral is important is, in this case, that arrow under figure B shows a stress fracture of the spine. So this scoliosis may not be idiopathic scoliosis, and may be secondary, that curvature of the spine may be due to rotation from a stress fracture in the lower spine. Older guidelines had recommended orthopedic referral for curves over 25 degrees. Now this is the scoliosis curve that's sometimes confusing with that scoliometer rotation. For curves over 25 degrees, that was typically when bracing of the spine with a TLSO was initiated. To measure the Cobb angle, you look at the superior end plate above the curve at basically the vertebra that looks the most angled, and then this inferior end plate of the lower vertebrae that looks most angled. And this is an example of what about a 25-degree curve would look like. However, I start treatment as early as 10 degrees. and I've had great success with that. So I actually recommend refers at least to myself for curves under 10 degrees. Now this may not apply if you're referring to an adult spine surgeon. I traditionally see them in the community still sticking to that 25-degree referral, but here at Lurie's, at least me and some of my partners, I like seeing them early. So the conservative treatment guidelines, what's currently being used by most people across the country is observation in curves less than 25 degrees. We typically think of scoliosis in 3 categories. Mild is 10 to 25, moderate is 25 to 50, and curves above 50 are severe. For mild curves, observation is recommended. For moderate curves, we recommend either observation or bracing, just depending on how much growth is remaining. And if there is a lot of growth remaining, they recommend bracing. And then for curves that are severe, above 50 degrees, surgery is recommended. Now you can kind of get an idea of how much growth is remaining based on this Risser score. That's looking at the iliac crests of the pelvis. And typically you can see the apophysis is that little white moon looking above on the tip of the iliac crest. And that starts turning into a moon at zone 1. And then as it grows, it expands into zone 2, and then zone 3, and then zone 4. And then eventually for Risser 5, it fuses to the bone below it. And that's when the patient's done growing. However, some of the treatment that has affected me, that I've adjusted some of my treatment protocols, are here. The BRACED study was a bracing study that showed wonderful success using a TLSO brace, as pictured here. This girl is wearing. And that shows a 72% effectiveness in preventing surgery when initiated at 25 degrees in children with a Risser score of 2 or less. Unfortunately, the brace has to be worn 18 to 23 hours a day. My guidelines for patients are that 18 to 23 depends on your activity level. If you're a child who's very active and playing sports, you'll probably be closer to 18. If you're a kid who's not into sports and you're doing other more sedentary activities, it probably should be closer to 23 hours. With this study, they determined that the number needed to treat to prevent 1 surgery is 3. And the idea is that for every 3 patients we brace, one of them probably is being braced unnecessarily. They weren't going to progress to surgery anyway, but there's no way of us knowing. One of the kids is going to fail treatment and they're going to need surgery in spite of bracing. And then one of those kids, you have actually changed the natural history course and prevented surgery. Another study that came out in about 2017 that helped change the screening guidelines is this, showing that Schroth physical therapy is an effective tool to prevent curve progression. In this study, half the patients were doing Schroth physical therapy, and the other half were just doing regular physical therapy for back pain or for postural deficiencies. And at 1 year, there was a 5-degree reduction in curve magnitude in the group that was doing the Schroth physical therapy, whereas the control group had an increase of about 3 degrees. And lastly, just recently, within the last couple of years, there was a study that came out showing that vitamin D and calcium supplementation has been effective in reducing curve progression, whereas 47 patients in the placebo group had curve progression, whereas only 22% of the patients getting supplements had progressed. Now, admittedly, these are 3 great studies that show 3 independent variables that are effective. To date, there is no study that shows using all 3 what the effectiveness of that is, but that's exactly what I'm doing. So my aggressive comprehension, multimodal approach that I call the trifecta of treatment is that I start vitamin D and calcium on all curves above 10 degrees. Now, if the patient's skeletally mature, not growing anymore, Risser 5, then I will often switch them to vitamin D only, as sometimes the calcium is a little bit poorly tolerated. I start Schroth therapy for any curves above 15 degrees as long as they have adequate growth remaining. And I start bracing. Now, bracing is the standard of care. I do start bracing right at 25 degrees for a wrist or two. Now, these are just guidelines. Certainly, if I have a patient who is nearing surgical indications, and even though their risks are 4, if they're right on the edge, I'll still hit them with all 3 modalities. I'll do whatever we can to make sure that we feel like we've done all we can to prevent the need for surgery. Traditionally, conservative treatment in the literature only acts to prevent the curve from getting worse. It hasn't really often been shown to make the curve get any better. However, using this approach, I have seen multiple cases where my curves are actually reversing, especially if we get to it early and the patient's young enough. So in this example, I have a 12-year-old female with a 30-degree curve. I initiated the vitamin D calcium. She's in the Schroth, and I braced her. And this is what she looks like in the brace. Roughly, you want at least a 50% correction while wearing the brace. And that's another thing I do differently than a lot of partners. I have an orthotist here in my clinic, and we work together designing the braces together. We get x-rays and we make modifications together. This isn't something I just send out and get a brace and hope it works. I get really my hands wet when it comes to getting the brace on. And here she is 3 years later, and she's graduated, bracing. She's not braced anymore. She's only on vitamin D now. We've stopped the calcium. She's doing home Schroth now on her own. She's not in formal therapy anymore. And her curve is 15 degrees, and it stayed there. And she loves the cosmetic benefits on top of everything else. And with this trifecta of treatment, I've really pushed the indications for conservative treatment and have been more conservative than I could otherwise be. This is an 11-year-old female with a 51-degree curve. She's a wrist or 0, and she's premenarchal. Under most circumstances, this is a surgery. There really isn't much role in the traditional literature for conservative treatment. However, this patient really was not in the right mindset for surgery. It was the first time I was meeting them. They had been getting conservative treatment from a chiropractor, which was, in my mind, not supported by the literature. So I ran her through our aggressive conservative treatment and said, you know what, if you fail and the curve gets to be 60 degrees, it's not that different of a surgery. Let's just give it a shot. Here she is in a brace. She was somewhat flexible. We still got about 50% correction, not as flexible as I would have liked. And here she is. It's only been a year later. She's still where she's at, but her curve's gone down to about a 43%. I wouldn't say we're out of the woods yet, but we're giving it everything we got. And so far, we're looking pretty successful. The pros and cons of this aggressive conservative treatment is I've actually had 100% success rate with patients that are doing all 3 arms of the trifecta of treatment. Now, that being said, this is a bit anecdotal since it's very difficult to get patients to do all 3. Either they don't want to wear the brace, they forget to take the vitamins, and really doing the Schroth therapy is quite a commitment. The other pros are that vitamin D and calcium is easy to take. For the patients that do fail, they feel like they've at least exhausted all their options. They're not being told the first time they're coming into my office that they need surgery, that they've at least given it every chance they've got. And one of the best things I think is there's no further restrictions. We're doing everything in the literature that has been shown to help. Everything else has not been shown to help or make it worse, so you don't have to worry about those other things. You can ride roller coasters, you can do sports, and just go on living your life every other way you can. The cons, of course, it is expensive. Schroth therapy isn't cheap, depending on if your insurance is going to pay for it. It's very time consuming, and it really takes a good family support system to really do it. Trusting a kid to do it on their own is just not going to happen. So when it does fail, we have to talk about surgery, unfortunately. The natural history of scoliosis is what dictates our surgical indications. Scoliosis is a growing condition. However, If the kid is done growing and the curve stays below 50 degrees, essentially we're done. Curves below 50 degrees do not cause any back pain. They are not supposed to keep progressing beyond skeletal maturity. There is some reports showing that there is more frequent back pain as adults, but not more severe and no loss of work. So I explain to patients, every adult has back pain in their lives. With scoliosis, you may have it more frequently, but not any worse. And curves above 50 degrees or 45 degrees for lumbar curves do have a high likelihood of progressing even after skeletal maturity. Now, after they're done growing, the curve does grow at a much slower rate, only about 1 to 2 degrees a year. And it's still not symptomatic until it reaches about 90 degrees, but at 1 to 2 degrees a year, at some point in your lifetime, that curve will progress to 90 degrees. At 90 degrees, the curve can be known to cause restrictive lung disease and congestive heart failure. So typically we recommend treatment at about 50 degrees, and that's because it's easier to treat when the patient's healthier, the curve is smaller and more manageable, and additionally the spine is more flexible at a younger age, so we can actually get the spine straighter, whereas doing these surgeries in adults, you basically are fusing it to keep it from getting worse. You're not making it any better. The operative treatment is a posterior spinal fusion with instrumentation. I like to do a lot of aggressive cuts in the bone to make the spine more flexible so that we can get better correction. Pedicle screws are placed inside the bone, inside each individual vertebra, and then we attach rods to those screws, and then we use those rods essentially to rotate that rod 90 degrees to put that scoliosis curve back into the sagittal plane where it belongs. The bone graft is then placed that fuses the individual bones of the spine to make it essentially one working bone so that scoliosis cannot form again in that fused segment. Now that does rob motion segments. The spine is stiffer afterwards, so we try to do as few levels as possible. In particular, if we're doing mostly thoracic bones, the amount of motion lost is pretty negligible. Here's an example of postoperative film using standard instrumentation of a posterior spinal fusion. You can see the difference where the scoliosis curve preoperatively on the left is now being used to give her a good lordosis and kyphosis on the lateral on the right. A typical postoperative course is not a surgery you recommend lightly. Surgery time is anywhere from 8 to 12 to 16 hours. Hospital stay is 3 to 4 days, even up to a week. They do get a month off of school. They cannot do gym or non-contact sports for 6 months, and it's really about a year before they're back to full activity. Now, after a year, the spine is fully fused. The rods and instrumentation and screws are not really necessary anymore, but we leave them in because it's another surgery to take them out. So we only take them out if there's complications. There are, of course, risks with this surgery. The immediate risks is blood loss. I do this surgery using Cell Saver, where we use their own blood and give it back to them during the surgery. Infection, they are on antibiotics in the hospital. Pain, here at Lurie's, we have a dedicated anesthesia pain management team for pediatrics who titrate the epidural, they control the PCA, so patients are actually very comfortable after this due to our outstanding pain management team. And there's, of course, the big elephant in the room is the risk of paralysis or a neurodeficit. We do have neurology on standby. We have a neuromonitoring in the room where they're doing EMGs, live motor and sensory feedback of the spinal cord during the surgery. If we overcorrect the spine, make it too straight, and the spinal cord's not happy, we immediately know about it and we undo what we just did. That greatly reduces the risk of paralysis, but unfortunately it's still not zero. And then long-term or delayed risks are infection. You can have a late infection. Typically, that's an indication to remove the hardware at some point, usually after the spine is completely fused. Sometimes the hardware can break, a rod can break, and that's typically means that there had an incomplete fusion. So it may mean a reason to go back and add more bone graft to help the spine fuse a little bit stronger. There are issues with the spine not moving in the areas that we did the surgery, but it can move above and below. That can sometimes lead to arthritis in the motion segments above or below as an adult. And that can also lead to increased kyphosis or scoliosis above or below where we did the surgery. That can be minimized by selecting the levels that you do the spine much more accurately. And also balancing the spine and getting a better correction has been shown to help reduce this. And now some of our newer instrumentation, this has become less of an issue. One of the downsides of using the standard instrumentation is that as you rotate that rod 90 degrees, you are correcting the scoliosis within 20 seconds. And that's a lot of force being placed on the spinal cord. Additionally, rotating that rod causes increased rotation of each individual bone. You're derotating the column of bone, but each individual bone actually rotates more. And that causes that rib prominence in the back of the patient to actually get worse. And because of that, that's a very uncosmetically pleasing result that patients don't like. So then there's another step where we derotate the spine. We derotate each individual bone opposite the direction we just rotated it in order to reduce that rib prominence. However, I do something a little bit different that none of my partners at Lurie's does. I use custom-made patient-specific rail, and that's much stiffer than a rod, and it has two benefits. As you can see in this picture, it does look more like an I-beam from like construction. That extra flat part greatly adds to the stiffness of the metal, so that we are able to get better corrections than we otherwise could. The average correction in the literature is about 50%, meaning a 50-degree curve after surgery is on average only about 25 degrees, which sometimes is not that pleasing to the patients. I would say my average correction is closer to 80 or 90% since I started using this custom-made instrumentation. The additional benefit is that since the rod is not completely round, it holds the rotation a little bit better. And we also do a simultaneous rotation and derotation at the same time. And as I'm placing the rod into the screws, we actually gradually correct the spine. So it's not all at once torque being placed on the spinal cord. We are gradually, within a matter of about 20 minutes, getting that spine straight as we seat that rod into the screws. Now the downside is because that rod is stiffer, it does have a higher likelihood of pulling those screws out of the bone. So we do have to put a few more screws in than we otherwise would. And this is an example of me using that newer instrumentation. This was a 55-degree curve in a patient, and post-operative on the right, you can see she's reduced down to about 8 degrees, which is about 80 to 85% correction there. And she's very happy with her results. Because of that custom-made instrumentation, I also am able to treat a lot of more severe curves than I otherwise would. This patient came to me with a 120-degree curve. And now I talk to my partners. I actually talk to some people across the country. I talk to some of my mentors at Stanford. And one of the treatments that was recommended to me is to admit the patient into the hospital to do halo traction, which is basically putting a frame around her forehead and pulling about 50 pounds of traction from her head up to gradually try to get the curve straightened out and more flexible prior to surgery. Insurance reasons, that really wasn't feasible. Additionally, the patient was not interested in having the disfiguring scars on her forehead from this halo traction. And the 2-week hospital stay, they were really against that. But knowing what tools I had in my arsenal, I used my custom-made instrumentation. I did not use any traction whatsoever and avoided all the complications with traction, which I saved out of this talk. But I was able to get her well balanced and got her curve taken care of and she's very, very happy that she did not have to go through the traction. Future directions that I would like to expand on within my clinic and as well as with Lurie's is ultimately I would like to make my Silver Cross or my new Lenox satellite a comprehensive multi-specialist approach to scoliosis. I would love to have a nutritionist here, or at least use our bone health specialist that we have, and who does referrals with an endocrinologist, and have them on site, and have them do vitamin D levels, so that we're not just blindly dosing everybody with the same standard dose. I would love to have a Schroth therapist here in my clinic. I know all the Schroth therapists in probably a 50-mile radius, and I talk to them. So it's like they work for me, but it would definitely be a lot better if we had them on site. Then I could control that variable. It'd get them in a little bit easier. Lurie certainly takes insurances that a lot of the outside Schroth therapists do not accept, which would definitely make it more accessible to a lot of my patient population. We also are looking into getting an EOS imaging. We do have this downtown that we share with Northwestern. I would love to get one here out in my satellite. It's less radiation than an X-ray, but it gives 3D images like a CT scan. So it's the best of both worlds. It helps with surgical planning, as well as routine surveillance of the curve. We can get more X-rays with less radiation. And something that Lurie's is investing in is getting a computer-guided navigation for the OR right now. This would allow us to place the screws with real-time reconstructed images to further ensure that our screws are being placed in the exact spot we want them to, further reducing the risks of surgery. And that is all I have, and we are open to any questions.
Thank you, Dr. Fuller. That was a great presentation. I think everybody probably enjoyed hearing about the operative and non-operative treatments for scoliosis. So we are running a little close on time, but there were just a couple questions that I had. You had talked about the Schroth physical therapy. Is this something that is best prescribed by you, or is it something that the pediatricians could make a referral for?
The beautiful thing about Schroth is there is a rigorous certification program for it. So it is, unlike bracing where I am very involved in the bracing, Schroth is relatively hands-off. The therapists do it all. So I think it's perfectly reasonable for a 15-degree curve if the PCP feels comfortable prescribing the vitamin D and calcium and prescribing Schroth on their own. But at the first sign of any progression above 25 degrees, I would get them into my clinic.
Excellent. Okay, thank you. And then one other question regarding like the first visits, first evaluation that you would see a patient. Do you request the images to accompany the patient, or are those something that's taken care of on the first visit?
If we have the images, I certainly want to see them. We try our best to try to obtain them, but certainly if the patient has a disc in hand, that's always the easiest way. If they don't have the image, it's no big deal. I have an X-ray on site. I can repeat them. You know, if there's not a lateral X-ray, I end up having to repeat it anyway. Or if the X-rays are more than about 4 months old, I'll repeat them to see if there's any progression. So we're certainly flexible to go either way. But if they have been done, I certainly want to see them.
Okay, Very good. I think that wraps up our question portion. You did a lot of answering questions during your presentation, which was wonderful. Dr. Fuller has his contact information up on the slide right now. So he's available. You can contact him through his office line, which is listed there, the admin office, and also his direct office, or contact him through email or an Lurie Epic in basket message. So thank you all for joining us today and learning about the scoliosis procedures and treatments available. And we do have one more ortho talk that is beginning at 5 o'clock with Dr. Laura Lemke on clubfoot. So one last thing, Dr. Fuller does see patients exclusively out at our new Lenox site at Silver Cross Hospital. Thank you everyone for joining us today. Enjoy the rest of your afternoon.
Thank you.
Thank you.